Hi, my name is Bryce Mendelson, and I'm a clinical genetics fellow at UC San Francisco. It's my pleasure to introduce the keynote talk today at the BioConference Live Genetics and Genomics Conference entitled Individualized Genomic Medicine and Update. It is my pleasure to introduce Dr. Robert Nussbaum. He is the Holly Smith Professor of Medicine at UCSF, the Chief of the Division of Genomic Medicine, and he leads both the Cancer Risk Program at the Helen Diller Family Cancer Center and the UCSF Program in Cardiovascular Genetics. His research accomplishments include identification of alpha-synuclein as the first gene to cause a familial form of Parkinson's disease. He's the co-author of 190 peer-reviewed publications and the author of a popular textbook in human genetics, Thompson and Thompson's Genetics in Medicine. Dr. Nussbaum has been on the board of directors of the American College of Medical Genetics and the American Society of Human Genetics, for which he has also served as president. And he was elected to the Institute of Medicine in 2004. Dr. Nussbaum, I look forward to your talk. Hi, welcome back. We're going to work on the sound for a moment, if you would. If you would ingratiate with us with your patience, thank you.
Okay, so can you hear me now? I apologize for the problem with the sound, but this should be now straightened out. So the talk today, I'm going to be reviewing what is individualized medicine. I'm going to talk about some myths that seem to have been floating around about the use of genomics in medicine, and what the current applications and future applications might be. I'd like particularly to focus on a useful framework for thinking about how one uses genomics as for testing purposes in medicine, and introduce you to what's called the ACE framework, the ACCE framework, and then I'll be running through some examples as well. So what is individualized medicine? To quote Francis Collins, who's a current NIH director, at its most basic, individualized medicine refers to using information about a person's genetic makeup to tailor strategies for the detection, treatment, or prevention of disease. Now, there are a bunch of myths that I think we are currently having to deal with in the use of genomics to individualize medicine. The first is that basic research findings are easily and quickly translatable into clinical applications. This is a myth. Just because one is doing research on humans, that doesn't necessarily mean that the information is immediately usable for clinical reasons in human beings. Second myth is that genomics is so cool, you don't need to gather the effectiveness data needed for the translation pathway. This is another problem that we're facing, and that is the need to develop evidence to show that when genomics is used to individualize medicine, it improves patient care. The third issue, and one that we are all grappling with, is that the patient and the providers of genomic testing, they get to decide what's useful, and the third-party payers and the governments that pay for healthcare are delighted to pay for it. And this, of course, we all know is not true. And finally, that complete genomic sequencing, as opposed to partial sequencing, such as exomes, etc., are going to solve all these problems. this also is not the case. There's still a lot of issues that are medical, social, and economic around this area. So let's talk about genomic analysis across the lifespan: preconception, prenatal, newborns, children, and adults. And we can start with thinking about the fact that when you have an issue with doing genetic testing, in addition to finding particular variation that you're looking for in order to try to explain, let's say, a particular disorder, you also, if you do broad genomic analysis of sequencing, we're also going to find what are called incidental findings. These are changes that are seen in the genome that are not directly what you were asking about, but still will need to be addressed and considered when found. Next in our discussion is to go over what I call the ACE framework. And this is based on the work from Moon Curry, who established the Center for Disease Control's Office of Public Health Genomics. And I find this to be a very valuable framework for thinking about testing. And that is to break the particular issues down to 4 areas: A, C, C, and E. The A being analytical validity, which means, do we have the right result from the right patient? And in particular, is this test sensitive, specific, and accurate? Clinical validity is slightly different. I'm going to be stressing the difference between analytical and clinical validity in just a few minutes. But clinical validity is really the ability of a genetic test to predict whether someone is at risk or actually has a particular disorder. In genetics, we often refer to this as the penetrance. Given a particular set of genetic variants, how frequently does such a person either have or will develop a genetic disease? In other parts of medicine, we call this the positive predictive value. Given a test, what's the risk of developing the disease? You also have the negative predictive value, which in medicine is often referred to as the rule out. If you don't have a positive test, if you have a negative test, how likely is it that you are free of the disease, that you don't have the disease, or you will not develop the disease with any increased frequency over that of anyone else in the general population? The second C is clinical utility. Even if a test is analytically valid and is predictive, how useful is it to the patient and the doctor to have that test result? And clinical utility is one of the key areas where we really need to develop evidence. And finally, there's the E, which stands for ethical, legal, and social implications of the work. Is there value to society to having particular test results, even if they're valid in both on the analytical and clinical side, and even if the patient or even the doctor thinks it's useful to have the test result? Is society willing to pay for it? So clinical validity, which we also think of as positive and negative predictive value. So what is the positive predictive value? It's the fraction of people with a particular variant, which could be a change in one copy of a gene, or change in both copies of a gene, because as you know, all genes, except those on the X chromosome in men, come in pairs. You get one from your father and one from your mother. And what we call the genotype is the pair of variants that are present in a particular gene. And then finally the haplotype, which is variants that are occurring on one chromosome but in different genes, that usually neighboring, close by. So multiple variants on one chromosome. Genotypes are 2 variants on both chromosomes, and an allele is 1 variant on one chromosome. So positive predictive values, the fraction of people with a variant who have or will develop disease. And the other side of this coin is the negative predictive value, the fraction of people without a particular variant who do not have or will not develop the disease. So if you think of the clinical validity, that's where we are. I have not gone over analytical validity at all. It's more of a technical issue involving tests and making sure that a blood sample drawn from patient ABC actually gets labeled properly and gets followed through the laboratory with the correct label on it, and that the result is tied to the correct patient. And these are technical issues that are very important, but we don't need to talk about this morning. So if we think about positive predictive value, negative predictive value, I would like to contrast them with two other related terms called sensitivity and specificity. These are frequently confused, and I don't want you to confuse them. Now, sensitivity is in people with a disease, how often is the test positive? So this is really a function of the quality of the test. It's a specific characteristic of a test. Specificity is the same way. In people without the disease, how often is the test negative? In other words, can the test be positive in people in whom it shouldn't be positive, so-called false positive results? These are both characteristics of a test. But a positive predictive value is, in people with a positive test, how often is the disease present? You can see it's sort of the reverse of sensitivity. And the negative predictive value is in people with a negative test, how often is the disease absent? The positive and negative predictive values are not strictly characteristics of a test. They are the characteristics of a test as applied to a population. And that's the main difference. Sensitivity and specificity are about a test. The positive and negative predictive values are about how a test behaves when applied to a particular population. So here's an example. Here, suppose you have a test that has a sensitivity or true positive fraction of 0.9 or 90%. That means 90% of people who have this disease will show a positive test. And the specificity, or true negative fraction, is 95%. In other words, 95% of the people who don't have the disease will show a negative test. So there's a 5% false positive rate. People who don't have the disease still showing a positive test. Now that same test applied to 3 different populations where the disease prevalence, the frequency of the disease, is either 1% of the population, 0.1% of the population, or 0.01% of the population. 1 in 100, 1 in 1,000, 1 in 10,000 people. You get different positive predictive values. So you can see this, what looks like a very nice and specific test. 95% of people who do not have the disease will give you a negative test. Only 5% of the population who don't have the disease will give you a positive test. When applied to a population where the disease is rarer and rarer, those false positives start swamping out all the true positives, and so the positive predictive value starts to fall. So for example, if only 1 in 10,000 people have this disease and you apply this test, 99.8% of all the positive tests you get will be false positives. These patients will not have the disease. Okay, so sensitivity and specificity are intrinsic characteristics of a test, while positive and negative predictive values are characteristics as applied to a population. And the prevalence of a disease makes a big difference to the positive and negative predictive value. Now let's talk about some other examples of genome analysis across the lifespan and why the ACE framework and why the sensitivity versus positive predictive value is important. Let's talk about diagnostics. So in diagnostics, we have a serious problem. It's a clinical validity problem. The ability to predict whether someone is going to be affected with a disease given they have what we think of as a positive test. And that clinical validity problem is focused around the issue of variant interpretation. And what I mean by that is the following. We can sequence genes, and we can find differences in people's genes from one to another. I'd just like to make a side comment here and make sure you all recognize, I'm sure it's all familiar to you, that there is no such thing as a perfect human genome. There's no such thing as a control human genome, or if you want to borrow a phrase from the geneticists who work on fruit flies, there is no wild type human genome, although sometimes it occurred to me that it'd be sort of nice to think that someone has a wild type genome, but that doesn't exist. We only know differences between any one individual's genome and some sort of a consensus reference genome that we think contains the most common sequence throughout the entire genome of human beings. And with ethnic differences and with a whole variety of differences, we know that this is a fiction. There is no real reference genome. It's an attempt to create a baseline against which any one patient's human DNA sequence can be compared. And the problem is that if you take any one individual's human genome and sequence it from one end to the other, you'll find between 3 and 4 million differences in that person's genome compared to the reference. I mean, think of 3 or 4 million. If you just focus your attention on the 1 to 2% of a human genome that contains coding sequence, the parts of the genome that actually serve as blueprints for proteins, you still have tens of thousands of differences with a reference. Well, how many of them mean anything? How many of them actually have a positive predictive value for a disease? And the fact is, we actually don't know for many of these variants. So, for example, how do we even try to interpret variants? We try to figure out whether a variant is pathogenic or disease-causing. We use a variety of criteria, none of which are absolutely confirmatory. They're all circumstantial. We try to build a circumstantial case for a variant being disease-causing. So, for example, is it absent or extremely rare in a large control population of some sort? We would think that a very common variant is unlikely to have a high risk of developing disease, of causing disease, because if that were the case, this disease would be rampant in the population. Second, does the variant result in a severe damage to gene function? And we can often predict that just by looking at the gene sequence change. Does it cause a premature stop? In other words, put a punctuation mark into this gene and make it stop well before it's supposed to complete? Or is it simply a change that substitutes one amino acid in the protein for another? These are differences which one can infer from looking at sequence. Does it follow the inheritance of the disease in a family? If it's a disorder where if you carry a gene variant, you have a high risk of developing disease, and there are many people in the family with that disease, can you track it and show that everyone with the disorder also has the variant? And does it do it in lots of people, more than 10 times, or fewer people? You can also ask if there's an amino acid change, was that amino acid conserved? In other words, in the same protein, but now when found in other mammals or found in birds or fish, is that amino acid changed or unchanged? In other words, what will Mother Nature tolerate for variation at that site? And we try to put all this information together to try to get some idea. And if we have less evidence than the pathogenic, we use a term called likely pathogenic. But unfortunately, there are many variants where we can call them neither variant pathogenic or likely pathogenic. And we also can't rule it out as being completely benign, that it's just a variation like eye color. So we're stuck in the middle. And there are many variants where we're stuck in the middle with this so-called inconclusive result. And these are called variants of uncertain significance. So here's some data from a paper that was published in April 2014 looking at hereditary cancer families using a large panel of genes. This could be anywhere from 12 to 15 to 16 different genes that are being tested. Now there are some panels that are up over 40 genes that cause hereditary cancer. And what we're doing is applying this panel to an individual and to a family where there appears to be some kind of hereditary cancer, but we don't know exactly what type. We're not sure. So we do a broad panel and ask, is there a variant in any one of a few dozen genes? And what this shows you is that somewhere between 65 up to 73% of the time, we don't find any variation that is suspicious of being causative of hereditary cancer. And somewhere between 7.2 and 9.8, between 7 and 10% of the time, we actually find the smoking gun. We find a variant that we're quite confident is disease-causing. But you can see in between, we have between 15 up to 25, 26% of the time, we find the change, but we don't know what it means. It's inconclusive. And this is a real problem for screening and for diagnostics, because you will end up as you add more and more genes to a panel to try to expand the set of genes that you're evaluating, you are simply by the numbers are going to start finding more and more variation because there's so much variation in the genome anyway. And this variation may be difficult to interpret. And so we're left with test results where the doctors and the patients have to really live with uncertainty. They don't know whether a particular variation is important or not. However, I should also mention that this approach can be very successful. This was a paper published last year from Baylor College of Medicine in the New England Journal of Medicine, where they reported 250 consecutive patients with undiagnosed diseases. Undiagnosed diseases are essentially disorders where we have a high suspicion that there's a genetic disorder based on the presentation, the family history, a whole variety of clinical clues would make a clinician very suspicious that this is a genetic problem. And instead of being able to make a diagnosis, these patients have gone to a variety of doctors, have had a whole variety of different sorts of blood tests and x-rays, etc., and no diagnosis has been made. And the bottom line for this is that these are 250 patients that were reported. They cover the whole gamut from prenatal to adult in age, the type of disorders. Many of them had neurological disorders as well as other organ system disorders, and that's not a surprise because the suspicion that these were genetic was based to a large extent on what their clinical picture was. But they may have had other sorts of disorders or even disorders not affecting the nervous system. So you can see that it's a pretty broad swath with an emphasis on neurological disorders and certainly covering the whole age range. And what was found was a total of 62 out of 250, or just about 25%. They were able to make a definite positive diagnosis by doing sequencing of a whole exome. In other words, the 1 to 2% of the human genome that codes for proteins, without any prior decision about what gene was likely to be affected. And what's interesting, of these 62, almost half were new mutations not present in either parent. And this is now becoming, although this is a well-known phenomenon, I think the extent to which these puzzling, undiagnosed diseases, particularly involving children, that turn out to be due to a new change in a gene that neither parent carries. And this, of course, has important implications if we think about using carrier testing to affect genetic disease. Half of the time, some of these severe disorders, you will not find the variant in the parent because it occurred new in the child. Another interesting aspect of this is that 4 of the 62 patients for whom a diagnosis was made, turns out had 2 disorders at the same time. And this probably is contributed to our failure to be able to make a diagnosis in these patients. It's because the 2 disorders were thought to be one, and that the fusion or the union of these 2 different disorders then presented a clinical picture that was very puzzling. It didn't fit any pattern. And it didn't fit a pattern because it wasn't a pattern, it was 2 patterns fused together. So, a couple of key concepts I'd like to also introduce, which is if a person has a disorder and you're trying to make a diagnosis, that's quite different from doing genetic testing or genome sequencing to screen for problems in an otherwise healthy person. And why is that different? It's different because if you remember back to positive predictive and negative predictive values, the likelihood of there being a disorder present in the population, the prior probability, plays a big role in your ability to be able to predict whether any particular variant causes disease. And if you have a patient who has a neurological disorder and you find a variation in a gene that is known for a variety of reasons, from basic research, for example, to affect brain development, the chance that that variation is important and perhaps plays a role in that child's illness is very different than if you find some other variant in the same gene in an otherwise healthy individual. So I think it's very important to make a distinction between diagnosis and screening. Second is the difference between what we call incidental findings and secondary findings. An incidental finding is something that you weren't looking for. So, for example, in these undiagnosed disease cases, suppose you find in a child with a neurological disorder a mutation in a gene that causes adult onset colon cancer. And it does not cause the neurological problem that the child has. You've essentially stumbled on a significant finding, but you stumbled on it. You certainly were not looking for it. And that would be different from saying, okay, in the undiagnosed disease setting, not only are you trying to make a diagnosis, but there is a set of other genetic changes which you ought to look for because they're important to know about, even if they don't explain the child's diagnosis. These would be changes that would cause an adult disorder that you could intervene on, that you could prevent, that you could ameliorate, something that it would be worth knowing about even though it doesn't explain the diagnosis. And that set of findings we call secondary findings. So as you expand the number of genes in the diagnostic setting, you are going to start stumbling on things, and you're also there will likely be, and there are recommendations now coming out from the variety of genetic provider groups like the American College of Medical Genetics and Genomics, that there are certain secondary findings that you really ought to look for. Of course, in screening, there are no incidental findings. And in fact, there are no secondary findings because you're not trying to diagnose a problem and you're not stumbling on something that's irrelevant to the reason for doing the test. If you do the test for screening purposes, everything in essence is incidental or secondary. Or nothing you find is incidental and secondary. Okay. So incidental and secondary findings. For example, which genes and which mutations should be included as part of incidental and secondary findings? So in a patient undergoing whole-exome analysis for developmental delay, should you seek mutations that cause hereditary breast cancer in the adult? That will be a secondary. Or should you report mutations you stumble on, which would be incidental findings? What do you do if you find variants where you actually don't know whether they're pathogenic? In other words, they're variants of uncertain significance. Should those be reported? These are really important issues that are being dealt with and discussed with a certain amount of heat and some light currently in the genetics provider community. And the American College of Medical Genetics has recommended currently that there are 56 genes that should be reported if pathogenic mutations are found. So these would be constituting secondary findings. If you've done a whole exome or whole genome analysis for any reason, because they represent a threat to health, they're not evident during routine health care, and useful interventions are possible. In other words, there's value in knowing these. This set of 56 genes will almost certainly change, will grow, will be pruned, and will change over time. Why? Because the number of useful interventions we have are going to increase over time. Another area that we can talk about is screening in adults to prevent serious adverse reactions. So this is now not someone in whom you're trying to make a diagnosis. What you're doing is you're screening. And the poster child for this, one of the best examples of this, is in the area of pharmacogenetics, the genetics that contribute to the effect and the impact of drug treatment. So there's a particular tissue type. This is the HLA, which is the region that the body uses to determine what is self and what's not self. It's what has to be matched when you're doing some sort of a transplant. Well, it turns out that there are certain immune variation at the HLA position that have a very high positive predictive value for whether you're going to have a severe skin reaction to an antiretroviral drug called Abacavir. And it's particularly the HLA-B 5701 variant. And so there was a study done where they looked at almost 2,000 patients with an HIV infection who had not previously received Abacavir, and they were randomly assigned to undergo the screening or just to receive standard of care. And what was found was that in a predominantly white population where the HLA-B5701 is much more common. It's a much rarer allele in other populations, whereas there are other HLA alleles or HLA variants that predispose to bad reactions with other drugs that are more common in other ethnic groups. So there's nothing special about the white populations except that 5701 happens to be more common among white populations. So 94% of the patients who did not carry do not carry this, and none of them had a hypersensitivity reaction to Abacavir. In other words, the negative predictive value of not having HLA-B5701 was 100%. You would not get the negative skin reaction if you did not have this variant. Whereas the 6% of individuals who did carry this variant were at a 50% risk for this hypersensitivity reaction, a positive predictive value of 50% for a severe skin reaction. So here we have a pharmacogenetic test that can be used to prevent a specific toxic effect of a drug. And this has to be determined through essentially a screening test. You're going to screen people to see if they carry this variant. This study was published in February 7, 2008, and within almost 1 year, February 19, 2009, there was a statement in the Journal of the American Medical Association from the International AIDS Society saying, screen for this and don't use Abacavir if you're HLA-B5701. The reason I point this out is what it shows is that 1 year after the data were available, the recommendations came through not to apply this piece of information. Now, I think some of you may say, why did it take a whole year? And others of you might say, only 1 year, that's very fast. In the medical area, I would say this is actually quite fast. It might be intolerably slow in the world of Silicon Valley, but in medicine, to have a recommendation go from evidence to a straight recommendation in 1 year is actually quite fast. Now, here's another example of genetic testing that has much lower positive predictive value. And these are what are called association tests, where you look at a group of people who have a disease and a group of people who don't have a disease and ask, is there any change in their genome that is statistically significantly present more frequently in the people with the disease than the people without. So here's a particular change. Unfortunately, it has a very clunky nomenclature, but it's called RS10757274, which is a change that occurs on chromosome 9. And it was found to be increased in people with coronary artery disease. That's what CAD is. And if people who had the AA on their 2 chromosome 9s, if they're considered to have the baseline risk of 1, no more or less likely to have coronary artery disease in the general population than if you had 1 copy of the risk allele or 2 copies of the risk allele, which is G, you went from 1 to 1.25 to 1.38. So this is a slightly increased, about a 1.4-fold increased risk of having coronary artery disease compared to the general population. But what happens when you apply this to I'm going to skip through this because it's just background information. Let's go right to here. What is the positive predictive value for these particular variants at that RS locus I told you about? In the general population, if you're 65 years old and you have no coronary artery disease risk factors, you're not a smoker, you don't have hypertension, your lifetime risk over the next 10 years, not lifetime, over the next 10 years of developing coronary artery disease if you're 65 years old is about 11%. If you knew that you had the 2 risk alleles, instead of being 11%, it would be 13.2%. And if you had 0 risk alleles, it would be 9.2%. If you're a 40-year-old female with no risk factors, once again, 2% over the next 10 years. If you had both risk alleles, 2.4, no risk allele, 1.7. So the point I'm trying to make here is that these numbers don't really change very much. In other words, knowing which alleles are present at this position has very little positive predictive value for coronary artery disease. And if you say, oh, well, that's just one place, we've got dozens of variations that affect this. So what is the what would be the value of combining a bunch of different risk alleles. And so they looked at 13 of these risk variations to generate an overall risk score. Here's the one we've just been talking about on chromosome 9, this RS497, etc., which has an average increased risk of 1.3. And you can see the others increase your risk by as much as 1.68. That's probably the largest one, versus one that's as small as only 8% or 1.08 increase. But let's combine them all. What happens? So what I want to show you here is, let's look at the fraction of the population that has either coronary heart disease or no coronary artery disease or coronary heart disease. And this is two populations. So with coronary heart disease is in the blue line, and the dotted line is without. And what you're looking at here is a risk score, not based on genetics, but based on what came out of the Framingham Heart Study, which is an intensive, decades-long study of risk factors that affect coronary artery disease, things like smoking, family history, and other things of that sort. So, and what you can see is that the two curves between the people without and with coronary artery disease, the dotted and the blue line, are very similar, but with perhaps some slight shift to the right of people who have coronary artery disease. If you use, instead of the Framingham score, you use the genetic risk score based on all 13 SNPs, the two curves are even more overlapping. And this is just another reflection of the fact that even if you combine all these, and even though they are all statistically significantly associated with coronary artery disease, they really do not change your overall risk for coronary artery disease significantly. This is the kind of test, these variants that are relatively common in the population and increase risk by 1.2, 1.4, 1.5. They're the kind of risks that are used for a lot of the direct-to-consumer testing. So here's an example of a test for type 2 diabetes carried out by one of my colleagues, where she was found to have a 25% lifetime incidence risk for type 2 diabetes compared to the average of about 21%. And I would say, this is in the eye of the beholder. But I would say that knowing that one's risk is 25% versus 21% is a very small number and of not great utility. The other problem with a lot of direct-to-consumer testing is that it tends not to be reproducible. So these are recommendations from the Center for Disease Control. Does this sort of genomic profiling using common variants to assess type 2 diabetes risk improve health outcome? And they said that there was completely insufficient evidence to recommend such testing for variants in 28 different positions to assess risk for type 2 diabetes in the general population, that the magnitude of the net health benefit from these tests alone or in combination was close to zero, and they discouraged its clinical use. And this, of course, is what led to the FDA enforcement for direct-to-consumer testing. In other words, very little positive predictive value, and also very little utility. Here's a problem with reproducibility, is that if you compare genetic test results from different companies, and here's for 6 different disorders. Type 2 diabetes is here on the bottom. Prostate cancer is one above that. Age-related macular degeneration is at the top of the list. And what they essentially asked 3 different companies was, do you think that this individual, they gave a DNA sample, do you think this individual's risk was increased, decreased, or unchanged? And there was a substantial number of people that were assigned to different risk categories by all 3 companies. One said increased, one said no change, and the other said decreased. When I say significant, anywhere from 0, in other words, there were no, for atrial fibrillation, there were no individuals who were assigned a different risk category, to as high as 9% for prostate cancer. 9% of people had completely contradictory results coming from the 3 different companies. And if you look through this, you can see assigned the same risk category by 2 companies. So, for example, 2 said it was an increased risk for age-related macular degeneration, and 1 said no change. That was 6%. Another 6%, one of the companies said increased, and 12.5%, 2 companies said increased, and 1 said decreased, or the other way around. So there's just very poor reproducibility and positive predictive value, which makes this sort of testing, which is why the FDA is so concerned about the clinical validity of such testing. Finally, I'm going to go to screening for preconception, and then I'm going to stop. This is a new and growing area which comes from the idea originally that there were certain ethnic groups that had an increased rate of being carriers for severe disorders that caused the parents no problem because they had one normal gene paired with the abnormal one. They were so-called carriers. But if a child were to inherit two abnormal genes, one from each parent, then that child would have a severe disorder. And growing from that has become the thought of, well, maybe we shouldn't be restricting it to just a small number of such relatively more common disorders in particular populations. So, for example, the classic example would be Tay-Sachs disease among Ashkenazi Jews, or sickle cell anemia among African Americans, or beta thalassemia among people from Mediterranean, Greek, or Sardinian origin. Instead of focusing on their ethnicity and focusing on particular genes, maybe we should just say, let's just offer testing to everybody for a large panel of many, many such disorders. So here, for example, is one commercial testing menu of over 100 disorders that you can be tested for, and as well as your spouse, and then you can address the issue of whether your child would be at risk for any one of these disorders because both you and your spouse were carriers. And I think this is definitely a wave, I mean, it's currently present now, and I think it's even more a wave of the future, of one of the earliest adoptions of a widespread genome screening type approach, similar to the screening that one can imagine will also be done for drug results. And there have been a position statement from the American College of Medical Genetics, which I don't need to go into, but just that whatever you screen for, it should be ones in which there's prenatal diagnosis available, that they are serious disorders that we can be confident are going to cause a disease in the child. Be careful about adult onset disorders, because we're screening prenatally for something that will not affect the child. And perhaps what we should do is have the child have the opportunity to decide for him or herself later on in life whether he or she wants to have the test. And so I think what I would like to do at this point, because the time is getting late, is simply to summarize the following. That there are obstacles to applying whole exome and whole genome sequencing for either diagnosis or for screening. The analytical validity, sensitivity, and specificity. And here the problem really has to do with our ability to detect abnormalities. When you do a whole exome sequence, you're not looking at the whole genome. You're only looking at a subset of the genome, and there may be important changes that are simply missed. So people have to realize and recognize that the sensitivity of a test when you're doing whole exome sequencing is not high. There are also certain kinds of mutations that are very difficult to detect with current technology, so-called insertion or deletion mutations that are difficult to detect. So the sensitivity is still not as high as we'd like it to be, but it is certainly getting better over time. The next is the variance of uncertain significance, that we have incomplete genotype-phenotype correlation. We have incomplete ability when looking at a variant to be able to predict whether this is going to cause disease or not. This is the genotype-phenotype correlation. We have too many variants of uncertain significance in most of the genes we look at. Another whole area that we have not had a chance to talk about but really does need to be addressed is a lack of electronic decision support. You could easily imagine that this genetic information is going to overwhelm practitioners. They're going to have difficulty figuring out what's important, what's not, what do I do with it, how shall I act on it, what does this mean for my patient. and we're going to have do a much better job of building decision support into our electronic medical records to allow practicing physicians to use this information in a time-efficient manner. And then finally, we have a lack of evidence base for utility for many of these. Even if we can accurately predict disease risk, is there anything we can do about it? And if it's useful to the patient because the patient says, this is something I want to know, and the doctor says, this is something I want to know because it'll help me not continue to try to find some other diagnosis. I at least can end the diagnostic odyssey, so it's value for me. There are often situations where a third-party payer will say, yes, but will it change the management of the patient in any significant way? And there I think we really need to build that. So with that, I'm going to summarize that we should remember the ACCE model when thinking about genetic testing, and we're going to go ahead now and bring this to a close and take questions. So first, I'm going to turn it over to Dr. Mendelson.
Thank you. A few questions to start with that have come in. Thank you very much, by the way, for that great talk. One question is, what studies do you know of, or are there any studies going on right now that are addressing any of these evidence challenges that you discussed, such as the need for evidence for benefit or change in management?
There are studies. They're mostly funded by the National Human Genome Research Institute, although there are others that are also being studied by PCORI, by the Patient-Centered Outcomes Research Institute, and others. So one of the areas is, for example, a large study going on at Vanderbilt University that is using their database of patients and patient samples to look at the value of knowing pharmacogenetic variants, and could we improve drug therapy by using the right drug for the right patient and avoid drug complications if we knew what the genetic variation was in patients. So that's certainly one large area where this is being done. There's also quite a few studies going on now that are looking at the undiagnosed disease area and what is the economic benefit of ending the diagnostic odyssey. If we can make a diagnosis by using genetic testing early rather than late, how many unnecessary and expensive tests could we have avoided? Those are just two examples, but there are others as well.
Thank you. Another question that I've gotten has to do with the use of genomic sequencing in cancer, in particular in enabling clinicians to use drugs to target cancers. And I think the question had to do with, along the lines of what you were saying, is how good are those predictive values when a genetic test suggests a particular cancer therapy? Is there a lot of evidence behind that particular drug will not be effective in that cancer, or is that also an area that is still maturing?
Question. So I'm going to put up a slide about targeted treatment because I skipped over this because of time. There are certainly now developing a whole area of treatment for cancers that's based on finding mutations in particular tumors that are sensitive to highly targeted treatment. So, for example, the poster child for this is the use of this drug, imatinib, the brand name is Gleevec, that's been used for chronic myelogenous leukemia, which targets a particular mutant protein that drives the development of this tumor. Similarly, there's a monoclonal antibody called trastuzumab or Herceptin, which is used for breast cancer patients that have a amplification of the HER2/neu protein. So these are the beginnings, and we now have many other pathways, many other specific targets, and many other drugs that are being developed. I would say that the level of evidence for these tends to be very high because the FDA requires that these drugs be used and tested in formal randomized controlled trials. The main difficulty with these drugs is the following: that cancer is a very shape-shifting tissue. It can undergo gene changes, mutations very easily, and so that many of these tumors, when faced with these specific anti-tumor agents, will undergo mutations which render them resistant because they're under selection from these drugs. So many of these drugs have had remarkable, fantastic initial results, but then over time, the tumor escapes control by these drugs. And what this leads to, I think, is the growing idea that these highly targeted therapies need to be combined, and the cancers need to be hit at multiple places at the same time to try to prevent the development of resistance. Similar to what's used now in antimicrobial treatment, that you would treat a difficult bacteria like tuberculosis, for example, with multiple drugs at the same time to prevent the development of resistance. One other issue is that there are certain mutations that are found in multiple different cancers. So the same mutation, for example, in the BRAF gene, shown right here, for which there are drugs like sorafenib that will target the mutation in BRAF that will really affect the growth of that tumor. Unfortunately, even though the same mutation is found in two different cancers, like melanoma and colon cancer, the drug is much more effective in melanoma than it is in colon cancer. And what this is telling you is that targeting just one pathway, if that cancer cell has undergone changes so that there are other mutations driving that cancer that can bypass this particular step, then even if you inhibit that step, you've bypassed it, and therefore the cancer will not respond to that drug. So the two issues we need to really focus on here is development of resistance and bypassing the effect of the drug. I'm going to turn back to Bryce now.
Thank you. One other question from the audience that I'd like to ask. You spend a lot of time talking about screening, and we know there are some screening programs already in place, like newborn screening, and then you mentioned some of this carrier screenings, some genes being more recommended than others, depending on what population you're talking about. Where do you see the future of screening? Do you see more screening for adult conditions like cancer syndromes? Do you see newborn screening expanding further to include even more diseases? Or do you see screening even focusing on new changes, like you mentioned, that happen in the genome that weren't inherited? But overall, where do you see the future of screening going?
Yeah, that's a really it's an interesting and important question, and I think there is no one single answer to that question. Go back to the ACCE framework. I think that what you'd want to do is set up screening in such a way that you would be detecting variants that have high positive predictive value, so that just by finding them, you will know that there is a significant risk for disease, and also that there's clinical utility. That knowing this will be important, and therefore make the expense of doing screening. Because remember, when you do screening, you're doing generally population screening, so that the number of tests you have to do is really quite high compared to diagnostic screening, where you're only focusing on people who have a particular disorder. I think that the future of preconception screening is very great. As the cost of sequencing goes down, the ability to look at essentially every gene in which mutations can cause disease when you inherit two mutations, one from each parent. I don't think that it's going to be that far in the future when such a screening test in a cost-effective way is going to be offered to every couple that's contemplating having a pregnancy. And what will be looked at will be genes that we know mutations cause disease, and we'll be looking only at those mutations that we know cause disease. Remembering the variants of uncertain significance are going to bedevil us for quite a while until we have that worked out. Of course, preconception testing is not going to help with new mutations. And so this enters into a much more ethically fraught area that I don't think we as a society have really grappled with, and that is screening prenatally widely. We are screening prenatally now for certain classes of birth defects, in particular chromosome abnormalities. And the development of non-invasive prenatal screening, being able to identify fetuses that are carrying extra copies of chromosomes 13, 18, and 21 by testing the mother's blood for cell-free DNA, is exploding as an area of great interest as a screening test. And I think that's not in the future, that's here now. And the ability to do prenatal screening is only going to be expanding to more and more serious birth defects. I think the issue that really bedevils us in that area is this whole idea of screening for non-medical traits, which, by the way, is also going on now. There's screening that's being done for sex of the fetus. And we already see certain societies where the sex ratio, the male to female birth rate, is shifting. And there are many more males being born than before compared to females because of prenatal identification of female fetuses and determination of female fetuses, because of social reasons that people believe that females are less valuable than males. This is a very serious, and to me, extremely troubling development of the application of screening. And I would hate to see prenatal screening expand along those lines as opposed to expanding along the lines of trying to prevent serious, debilitating, and life-limiting illness. Finally, screening for adult disorders. There's already now a discussion going on in Israel about screening for hereditary breast and ovarian cancer. There are 3 particular variations in these 2 genes that are responsible for the vast majority of hereditary breast and ovarian cancer, and it's present in a few % of the population, not 1 in 500 the way it is in a general population such as the United States. And so I think what you're seeing there is an argument not about should screening be done so much as is it cost effective and is it useful. And I think as more and more, as the cost of screening goes down and as our ability to intervene in these disorders improves, we're going to see more and more adult screening going on in society. But once again, please remember the ACCE framework. That is a discipline when thinking about these that you should always apply. And I think with that, I'm going to have to call it quits for the morning, and thank you all for your attention, and hope you enjoyed the session.
Thank you very much for attending this session. It was a pleasure to listen to Dr. Nussbaum. If anyone attending this wants to discuss this further, I believe that the BioConference has a forum where attendees can discuss amongst themselves. And I hope this was enlightening to you. I certainly enjoyed it. And good luck. Enjoy the rest of the conference.